What really leads people to surgery? When do you need surgery? When do you not need surgery?
If you grab 100 people off the street, random people, and take MRI scans, 20% of those people will show some form of stenosis or narrowing in their spinal canal, and up to 60% of those will show disc herniations on their scans. These are asymptomatic, people that have no symptoms. All medicines are a calculated dose of poison because anything in excess is toxic for us. You can seriously hurt yourself with ibuprofen.
Got to the 5th session and she came and her husband was by 2 arms walking her into the clinic. It took her about 20 minutes to get from her car to in the clinic bed. She said, I was laughing with my friend last night and just hysterically, we was having a good time. And now I'm like in so much pain I can't even control. So I sent her for an MRI literally right then. Walked into the clinic an hour later. Radiologist called me and said that she's got around 18 pathological fractures all down her spine and has tumors that have invaded everything. Welcome to the Healthcare Revolution podcast. I am really excited to talk about this topic today of spine and specifically what really leads people to surgery? When do you need surgery? When do you not need surgery? I love treating the spine. It is by far my favorite body region to treat. And there are way too many people signing up for surgeries way too early. And there are people that wait too long. And there are people that need to be there and there are people that don't. And today we're going to talk about the people that actually need to be in surgery. What are the other options that you have? And why is it important to have surgeons in the healthcare corner? Because it's an absolute necessity in rehab and in back pain that we have them, but we have to know when to utilize them. And if we overutilize them, they become very overwhelmed. Their schedules become packed. But we want to do our jobs as healthcare providers to triage that, to make sure the right patients get to the right specialists at the right time. And sometimes that means expediting care for people, and sometimes that means we need to shift you in a different spot. So we're going to dive into all those things, but by the end of this episode, these are a few things that you should know. So you should know how to tell the difference between between pain that needs to be watched and pain that needs action. When physical therapy can genuinely be enough and when it's going to help, and how long to give it before you actually worry about it. Where injections actually fit in the decision-making process, the red flags that mean surgery and that you shouldn't wait, and the exact questions to ask before you ever say yes to any procedure. And obviously, these are some pretty bold promises, but I promise you really tune into this session, this podcast. All of these questions will be answered. Alex Davis is joining us here. He is an absolute expert in this specialty. He works at Summit Brain and Spine as a physician assistant for Dr. John Edwards, one of the top neurosurgeons, I believe, in the nation.
Oh, yeah.
And he is Alex has seen thousands of cases of back pain over his career. He had a unique start. He's a collegiate athlete himself, and then went on and was an athletic trainer and working with collegiate athletes, and then joined the Summit Brain and Spine team, working as a physician assistant in the neurosurgery world. So excited to have him on the podcast. Alex, welcome to the podcast.
Thanks, Brad. This is awesome. I appreciate you inviting me over.
Yeah, it's great to have you here, and I'm super excited to dive in this topic because we do rounds every week where we talk about, these difficult conversations, talk about many minds approach where we all come together as one collectively and work together as a team. And your expertise in this area is really crucial to get out to the public on what they need to know about these types of surgeries. So again, welcome.
I appreciate it. Yeah, this is kind of fun to see. I'm glad you've taken this on because I think just in general, it's a needed service to put out good information. So yeah, also appreciated your efforts, and it's recognized that you're doing your part to help out.
Well, thanks, Alex. I don't know if I've made full clarity with you, but the reason I started this podcast is because of you.
Oh, really?
Yeah, your team. you guys started your podcast,
Mhm.
and it really inspired me to get out the message
Yeah.
because I saw what you were doing. I'm like, this is what we all need to be doing.
Yeah.
I remember your med talk talking about social media
Mm-hmm.
and educating the public,
Yeah.
because we have all these influencers, all these
Right.
bloggers that are getting out information to the public that a lot of it is inaccurate.
Yeah.
And we are not courageous enough to have a voice.
Yeah. Yeah. It's hard when you're maybe the minority or not the popular opinion. And then some people, I guess, shy away from the attention, but really for physical therapy and conservative care, you're a leading expert in the community. And I think your opinion is very validated. So it's helpful if people can have a chance to hear and see what your thoughts are on topics.
Yeah.
And people are going to social media for information. That's really where it's happening. So
Yeah.
if we're putting out the right information through the right avenues, I think we can reach a lot of people and help the community.
Yeah, absolutely. And, you know, if there's anything I can push out to the community is make sure you understand your sources.
Right. Yeah.
And that's really what we've kind of established together as a community, or at least we share in one of our values, is we want to get you the absolute best resources to make the best clinical decisions in your
Right.
life.
Yeah.
You know, it's not that we're saying that these influencers are wrong or AI is wrong. There's
Yeah.
places for them, but
Yeah.
ultimately we believe that we have studied so many years, decades in expertise in these areas, and we want to share that clinical information with you.
Right. And then just, I mean, I think now more than ever, it's pretty known and prevalent that a lot of these things are curated. So there's a lot of incentive or ulterior motives behind a lot of the things that are out there. So again, like you said, just understanding your resource. Where's your information coming from?
Yeah, absolutely. Well, tell me what started your whole medical practice. You know, what sports did you play in college?
Baseball was my thing. I've been around the game of baseball, I think, since I was born. Having older siblings, following brothers, I was the bat boy for their teams while my dad was coaching, and then eventually played myself. And then when I was done as the athlete, because I was eventually told that I was not good enough to make money doing that. So
That's the worst.
I know. So then I always had a passion for athletics.
Like, hold on, I need to have a career on top of this.
I know, dang it. That
Real
was
job?
all. I had all my eggs in that basket. And it's funny because my son is that way now too. My son just talks like that's a fact. It's
That's
just a
his
given.
career.
He's like, yeah, well, yeah. When I'm a professional athlete, this is what I'm going to do in life. And I'm like, you're 12. Maybe let's think about Plan B.
Is he
Anyway,
going to Cooperstown soon? Or did he?
no.
Okay.
But anyway, yeah. So I mean, always been around it. I like the environment. That's kind of my comfort zone. So then I thought I could treat the athletes, which was a fun way to. Also, I'm interested in medicine. I've always been interested in the human body and medicine as well. So trying to kind of mesh the two, that's athletic training.
Yeah.
So triage and first responder care and a little bit of the therapeutic rehab, and then blend that into the athletic world. So that's what I did for
And if
about 8 years.
if anyone knows about athletic training, there is an extensive amount of hours and effort that it goes into becoming an athletic trainer. So going from a collegiate athlete to an athletic trainer, now to a physician assistant, is quite the journey.
Yeah.
Tell us about the training just to become an athletic trainer.
Yeah, so it's changed a little bit over the years. When I was doing it, it was a new idea that a master's degree would be the minimum requirement. Now that's the standard. You have to have a master's level education to be able to certify as an athletic trainer. But I was early on in that, so I did a master's program in athletic training and then got certified because I had made that decision later on. So I already had a bachelor's degree, went through a master's program for athletic training and got certified that way, and worked in that field for about 8 years. And like you were alluding to, it's demanding and not a lot of compensation because it's not recognized by insurance companies. So somebody who's employing an athletic trainer cannot recuperate any of that expense because there's no billable events. You can't bill for the services of an athletic trainer. It's all an expense for the employer. So that means your salary gets capped. They can only afford to pay so much for those services. Whereas you get into the higher levels of education, then you bill insurance and you can recuperate money for those expenses. So you get capped. You get worked a whole lot. You're kind of at the beck and call of the coaches and the administrators and whatever it is that the team
Nights,
needs.
weekends.
Yeah, and I explain it this way, is that professional sports, and now college sports really are professional sports as well. You're essentially, it's the entertainment industry. They're putting on a show, they're producing a product and putting on a show for an audience to come watch and buy tickets and merchandise and things. And you think of the entertainment industry, that's people's leisure time. So nights and weekends, and you take your show on the road and you travel with it. So it's
definitely not a family job.
It's not. That's what I ran into.
It sounds really cool for a single person.
And it was a blast. I got into that right as I was newlywed and out of college. So my wife had a job. She was working full time. We didn't have kids. And so I was having a blast and really didn't feel the stress of that. But eventually started having kids, which takes more time, takes more money. And then you start to feel the kind of the pressures of life.
There's a constraint, yeah.
Yeah. So, and I wouldn't trade it for the world. Super glad I did that. All kinds of life experiences and relationships and all good things came out of that. But eventually hit a point where it was time to move on. So went back and got some more education. And
you think you got a master's degree,
yeah, well,
thousands of hours,
yeah.
8 years into practice, and then switching.
And then into PA school. Yeah.
And tell me the level of education for PA.
It's a master's program, and so similar, but quite a bit more intensive. They mirror the educational model after medical school. It's a very similar model, same concept, same information is taught, essentially. It's 7 semesters, traditionally.
And you just knocked it out of the park because you'd already been practicing.
You would think, right? I know.
You're like, that's not the case.
It's a whole different thing. In that 7 semesters, I think there were 2 weeks that were spent on orthopedics. So for 2 weeks, I was super comfortable. And then the rest of the time, very uncomfortable. But yeah, so you go through 7 semesters of pretty intensive training and education. The difference with medical students is that they're not done at that point. They have to go specialize. So they take on residencies and fellowships, and they become experts in their one area. Whereas physician assistant, you finish your basic medical training, and then you're into the workforce. So
and you essentially get kind of trained on the job.
On the job,
to do
yeah.
your specialty.
Mm-hmm. Yeah.
So once you finished PA school, then you joined Dr. Edwards' team.
I had
brain and spine.
I did. I had a little bit of a transitional job for about a year, and it was full time in the personal injury space.
Oh, okay.
Which
That's PI.
I didn't know anything about that industry, and it just turns out that was really favorable to transition to neurosurgery. Because
just so everyone knows, that's just general accidents. If you get
car
in a car
accidents,
accident.
yep, personal injury and working with auto insurance and car accidents.
And was that more on the primary care level, or was there...
exactly, yeah.
Okay.
So I was functioning kind of as a primary care provider to assess
Where was this at?
overall condition. It was here locally in the valley.
Okay.
And I did that for about a year. Great experience. It was a good way to get my feet wet and get going, and then started to develop a relationship with Dr. Edwards and the folks at Summit. And that just naturally kind of flowed into another opportunity, and have been there for about 5 years now.
That's awesome.
Yeah.
And if you know the Summit Brain and Spine team, they are just something to speak about, man. The community that they've developed is just phenomenal. It's what every provider has dreamed of. People working together as one. Everyone in the same room discussing their own viewpoint and really getting us to look through different lenses. It has really opened up my eyes to so many different things, and gets me to work with a ton of different providers on these cases to get out of what we call the silo care, which is then focusing on this many minds approach. Is let's work together.
Yeah.
And let's figure out what's best for the patient, because each one of us holds a piece to the puzzle.
Right.
And we become specialized in that area, and that's all we know.
Yeah.
And sometimes we become biased in that area because, for instance, if, say Alex sees his patients, he might get a lot of patients that have failed physical therapy. He can develop a bias that says everyone fails physical therapy. I might get all the patients that fail fusions. And I develop a bias that, those fusions fail all the time. But ultimately, I see 85% of my back pain patients get better.
Yeah.
But he's getting all the ones that don't get better,
Yeah.
right? So it creates, and same thing with these fusions. He might see 90% of these fusions just thrive. I see the 10 to 15% that don't.
Yep.
Right? So we all develop these own biases in our own world. But when we come together collectively as one, we get to challenge those biases.
Yeah.
And that's what I love. It's like, okay, you're seeing it through a different lens.
Yeah. Yeah, no, that's a perfect perspective. I think you put that perfectly. Is you definitely get a biased population. So I naturally end up seeing the people that make it all the way through the process to end up at surgical decisions, when I don't see the vast majority that never made it that far. So yeah, I'm getting kind of a biased exposure to these things.
Mm-hmm. Yep. What do you do with that bias? How do you challenge it yourself? How do you challenge your own?
Yeah, there's a lot of, I guess, for better or for worse, we have a healthcare system that naturally challenges that. So we use private health insurances that these are big money businesses, and they've put their resources into understanding what typically is the most successful strategy and what they're willing to cover and pay for. Sometimes it's a burden, but for the most part, really, it's for our benefit to make sure that things are done.
And benefit on both ends, right?
Yeah.
On the patient and the provider end, because it sometimes ties your hands.
It does,
It's like, well, this is the process that we do need to go through before we get to this end surgery.
Right.
But a lot of the research supports it.
Exactly. Yep. So there's reasoning behind those things. It feels like a burden a lot of times, but really, you have to understand, kind of like you're saying, a biased opinion. I see my side of this argument, but you have to really put yourself in the other shoes of they are making their decisions based off the information they're given. So I can see something in clinic that just looks really extreme and really urgent, and I can just tell them this person needs surgery because of X, Y, and Z. And they will just objectively look at that, and they may not really understand the entire picture because I didn't really support my story when I handed it over to them to ask permission. So it puts it back on us as well to do our due diligence. Have we really checked these boxes? Have we really explored these things? And could I realistically defend that on paper to show someone else that has zero involvement and help them understand what the scenario is? So there's definitely one way that it comes into play, that we're put through these checks and balances. And then just anecdotally as well, having lived through it myself, I do get to see a fair amount of patients, thankfully, that come back and say, I'm better. It was great. I didn't think so, but I went through the steps and I do actually feel better. So I've seen it be successful as well.
Yeah, and it's pretty incredible when we follow the steps.
Yeah.
And some of the things that I teach patients is, once you have a surgery, there's no going back on that surgery.
Right.
But if you've done all the things, you've taken all the steps that we're going to talk about today. We might not talk about every single one, but if you've gone through A, B, C, and D, and you got to the end result, and none of the stuff before worked, that surgery is the best option for you.
Right.
But if we just skip all the steps and say, I need surgery for convenience, or because my neighbor got it and he said it was the end result for him, and say, for instance, heaven forbid, the surgery does not go well, which is a small percentage of the time, there might be a lot of regret there.
Exactly.
And some things that you could have done.
And that's my role, is to help people understand that they have not seen that or experienced that. I have seen the ones that have not turned out well for a variety of reasons, and it is miserable for everybody involved. Obviously, the patient is not happy and struggles with life. The physician or the surgeon that's trying to help is also, that wears on you when you've tried to help someone and they actually came back worse off. It's an emotional weight on you. It's a physical weight, because then you have all of the follow-up care and all of the things that need to be done to try and correct that or improve that person. And then all the family is involved. There's just so much to it that it is the worst thing. The worst thing in all of surgery is a complication. The people that have issues after surgery. So if there's anything we can do to give you the best chance.
Could we talk about some of those complications that are just like really not fun?
Yeah. Yeah. I mean, first and foremost is the incision. So people that can develop infections or their incisions just don't close. And there's ways that we can influence that. We know certain things can increase your risk of that. So overall health, diabetes, obesity, smoking, right? And just poor.
Some of those things are
health.
out of your control as a provider, right? Like you try to take those things against her. You have to know all of that, right?
Yeah.
And you guys are really good at having a good system to identify if they have any of those conditions.
Yep.
But
Yeah.
if patients like, I have to get the surgery, right?
Yeah.
That's a complication that can happen.
Yeah. And unfortunately, we have to have that frank conversation with people. I can see your problem. It's apparent on an MRI scan. I can see your disability and the symptoms that are really wearing you down, but I would not do surgery because you have these modifiable risk factors that put you at a pretty high risk that you're going to come out worse off.
Oh, that conversation is so hard.
It's hard. Yeah. Yeah. And
But in the end, you're probably saving them, right? Because
Yeah.
there's a good chance they might get that infection or might have
Yep.
those, things happen during surgery.
Yeah.
And you're
Yeah.
essentially being the gatekeeper saying, yes, you have the things, but you also have these things that are going to hurt you.
Yeah. Yeah. It's hard to
It's my job to be the judge.
be the bad guy sometimes because those are, unfortunately, those are the ones that can walk away unhappy.
Yeah.
If you can't approach that right, and this is a whole other conversation probably, but connecting with people is the first step.
Yeah.
Somebody has to trust your response
Yeah.
and know that you're coming from a place of really looking out for their best interest. If you have no relationship and you have no connection and you just tell somebody, sorry, you're overweight, don't do surgery,
Mm-hmm.
then they walk away unhappy,
So true.
bad reviews online, right? Telling
Yeah. And you're just doing your
all
best
these
for the
things.
patient, and all of a sudden then
Right.
they're attacking you and
Exactly.
leaving you poor reviews, and you're like, ugh.
Yeah. So it is a little bit of an effort to actually make sure that you have some connection with these people and understanding so they can get a sense that this is coming from a place of caring. I'm saying no because I
Gonna
think
hurt
that's
you
better
more.
for you,
Yeah.
right?
Yeah, absolutely. So talk to us about, and when we talk about the majority of the population,
Mm-hmm.
I think we could both agree on that your guys' schedules get really full.
Right.
But we also could agree on that the majority of people with back pain don't need surgery.
Right. Yeah.
But a lot of people think that they do.
Mhm.
Tell us what that gap is for most people in society that you've seen.
Well, yeah.
Why do a
it's-
lot of people think, oh, my back, I threw my back out, therefore I need surgery? Why do they think that?
Well, first of all, back pain is one of the top at least 3 complaints in all of medicine. One of the most common complaints in all of medicine is back pain. So it is prevalent. Everybody is having back pain.
Mm-hmm.
And like we alluded to, surgery is a risk versus benefit analysis. What are the risks of doing a surgery versus what's the proposed benefit of it? So we have to take into account which of these people are having the back pain that have the concerning symptoms to say that their risk or their benefit of the surgery far outweighs the risk of intervening. And then that's where we rely on the folks in the physical therapy world and chiropractics and pain management and our primary care providers and anyone else that's interacting with this patient to triage and say this one seems to be the one that stands out as potentially not getting better or some concerning symptoms, or this one potentially would say the benefits are going to outweigh the risks.
Yeah. Tell us, how do you define conservative therapy or conservative treatments?
Yeah.
Most insurances will say you have to do at least 6 weeks of conservative
Mhm.
therapy first.
Yeah.
Talk to us about the definition of conservative therapy in your eyes.
Well, I mean, really everything under the sun that's not surgery is conservative care.
Yeah.
Specifically, though, the one that is really put under the microscope when we're talking about insurance approvals is physical therapy. But that's not maybe the only thing. There's a lot of ways that people can find to treat and manage symptoms without.
Rat some off
getting
for us.
over-aggressive.
What are their options that people
Yep.
that often go missed?
Chiropractic care, I think, can help a lot of people, which people give me the look when I say that in a surgical clinic, but chiropractics can offer a lot in medicine. I think they have a great tool to be helpful. Massage therapy, the acupuncture and dry needling, the specific movement programs like yoga and Pilates, and overall managing health as well. So working closely with a primary care provider to manage hypertension or diabetes or obesity
Yeah.
and just get yourself healthy.
And a lot of people think either, at least in the medical model, it's therapy or surgery.
Mm-hmm.
But then there's this like wide way in between of so many other things, right? And I really
Mhm.
want to emphasize conservative treatments is not just PT.
Right.
It is a lot of other things, and we've discussed just barely. But tell us about when these conservative therapies are enough. Like, why? What have you seen in your practice? You've seen people come in, they're like, I need the surgery, absolutely need surgery. You do your best to say kindly, we need to actually start here, and then I'll see you in 6 weeks, or I'll see you in 3 weeks, and we'll touch base, whatever.
Yeah.
What have you seen working well?
Yeah, well, a little bit depends on the diagnosis initially of what is it that we're actually getting after. If it's a malignant brain tumor, then it's not really something that conservative care is going to address.
Yeah, we don't need
people
conservative
understand that,
therapy
right? Yep. If it's something like an acute disc herniation, so somebody's been active, they feel like they threw their back out and they're having intense back pain, maybe radiation in the legs and things like that. The way that we approach that is we want to start at the bottom rung of the ladder and gradually move our way up. Essentially, we have a chance for those things to get better. Disc herniations on their own are not a reason to jump to the end of the algorithm, right? So we know that I'm trying to remember these statistics now, adults over the age of 60, asymptomatic, so somebody that has no symptoms, if you grab 100 people off the street, random people, and take MRI scans, 20% of those people will show some form of stenosis or narrowing in their spinal canal, and up to 60% of those will show disc herniations on their scans.
With no pain at all.
These are asymptomatic, people that have no symptoms.
Yeah.
So we don't just focus and treat a picture. You're treating the actual person and the symptoms.
And I love how you started the podcast. You said, we're going to look at your MRI scans, but we're also going to look at your disability. Right? It's marrying both the symptoms and what you're doing and your functional activity with what we're seeing on the picture.
Right.
Because the picture doesn't tell us everything. And
Correct.
A lot of society thinks, I need to get an MRI because that's the gold standard, which can be helpful, but that's not everything.
Right.
That's just part of the picture. And we need to make sure clinically it's matching.
Yep.
Because you might show a bunch of stuff on your MRI, but it doesn't really influence your pain based on what your pain is telling us.
Correct. Yeah.
So
Agree.
I love that. So what are you seeing? So say it's a disc herniation that you send back to PT. In your experience, what's happening? Are these people progressing? And then we'll talk about like the ones that don't.
Yeah. A vast majority get better. We know that. You guys know that. Insurance companies know that. A vast majority of acute disc herniations will get better. It's upwards of 75% of acute disc herniations will be significantly improved at 3 months from the injury. So we want to give it some time. We want to try and avoid the aggressive surgeries.
And tell us from both the science you understand and clinically, what happens to those disc herniations anatomically speaking?
Yeah. So the disc material is a soft, pliable material. It's not a rigid bone. It has the ability to adapt and change size and shape depending on a few variables. So your body will naturally try and reabsorb any herniated portions of a disc because that's where it has its blood supply and nutrition comes from. So it's a natural process. The body will try and reabsorb that. Not successful every time, but it can definitely happen. So I've seen myself plenty of times an MRI scan with a big, ugly looking disc herniation, and a follow-up scan shows that it's better. They can get better.
Lonnie, can you check that time and let's get that recording? That was what you just said is so important for people to understand that you've seen it. You've seen it clinically. You saw the picture, you saw the follow-up, you saw that reabsorbed into the tissue. Yeah. And that's what
they get better. So essentially what we're trying to do is buy time for the body to repair itself. An injection, and this is maybe a bit of a misconception as well, a steroid injection is not changing any physical features of the tissues or what we see on a picture. And medication is a chemical, and it's treating a chemical reaction, so pain. And a steroid injection is for pain. It doesn't change what things look like. And that is oftentimes a great way for a short-term benefit. You can feel really good after an injection, and that's great. We want you to feel better and have your pain under control, but it's not changing what the picture looks like. And then
That's your second one, Lonnie.
the
That
manual
was good.
therapies, the manual therapies with what you guys are doing are really the long-term answer. Correct me if you think this is wrong, but I look at pain management and injections as acute, quick control of pain, and then the therapy gives you your chance for long-term success or longevity.
Yeah.
You don't go to one therapy appointment and come out and say, I'm better now, I feel better.
Yeah.
It's a long-term
it was
game,
that.
right? It's a long-term game. But if you can have this window of time where your symptoms are managed, your pain is manageable, you're free to move, and you're working closely with a therapist and improving your function, regaining range of motion and strength and stability and things, then essentially when that medicine wears off and you've built up a better strength and foundation for your body to move well, hopefully the symptoms and the pain don't come back.
Yeah. And I love what you said. I really want to hit this home, that chemical component with a chemical steroid, right?
Mm-hmm.
When the body is pushing on a disc for a period of time, it can leak a chemical that can be very toxic to nerves.
Mm-hmm.
And sometimes it's the disc coming out, sometimes it's just the toxic chemical. So we use these steroid injections to inject at that site to essentially fight chemical with chemical.
Mm-hmm.
And like Alex was saying, it's only reducing what you feel.
Correct.
Your brain's interpretation of the pain.
Correct.
But if there is a disc herniation, it doesn't change the actual mold or the morphing that's happening with the actual disc.
Yeah.
So-
I don't know why this came into society, but the misconception is the difference between inflammation and edema. People think that they say this is inflamed, and they're thinking like physical properties, that something is engorged or enlarged or a bigger size. Inflammation is just a chemical process that is producing what we feel as pain. But it doesn't describe the physical characteristics of thing. If you say something is swollen or it's engorged or enlarged, now you're talking about something that's actually bigger than it was. That's not really what we're talking about. Anti-inflammatories are against the inflammatory process. It's just chemical mediators, these signals telling each other to create pain.
That is a really good distinction. And why do we not use NSAIDs as much for swelling?
Yeah, it's not
Why
necessarily.
are we kind of like starting to lean away from it now?
Yeah, because you're stopping these chemical mediators that are telling your body to heal. Swelling is a natural occurrence. The reason why we have these things happen, you have an injury and then it gets swollen. Your body is sending all of the mediators and all of the cells that will help repair and fix things, and then it just shows that it's bigger because there's more things happening there. Anti-inflammatories stop all of these communications back and forth. It can help with pain, but then your body may not actually be repairing and fixing itself as it should. So you just use those things with caution.
That's a third one, Lonnie. That was a really good explanation. A lot of people think that NSAIDs are the end-all, be-all, but we've learned through science and over time that too much of anything is not helpful.
Oh, yeah,
right?
yeah. Yeah, I tell people medications, and if you really think about it, all medicines are a calculated dose of poison, because anything in excess is toxic for us. You can seriously hurt yourself with ibuprofen.
Yeah.
Right? You're trying to help yourself, but somebody, lots of people have studied this out to find the therapeutic range, meaning enough of the medicine that it's producing a benefit, but not too much of it to where it's hurting you.
Yeah.
So it's kind of this calculated dose of this poison that can ultimately harm and kill you, but if you take just this right amount, it's helpful.
Yeah.
So kind of understanding that, you just cautious with medicines.
Yeah.
There's a lot of areas where medicine is the answer. So people trying to treat hypertension and cholesterol and diabetes, right? If you are a type 1 diabetic, you are reliant on a medicine to replace your insulin and what that's doing for you, right?
Yeah.
But that's not what we're talking about. We're talking about medicine for pain control, really.
Yeah, absolutely. And even things like ice. We've learned ice over the years. There is that middle portion. You have enough or you use too much. There's like these end spectrums that are not that great, right? And we've learned that we need ice in the first 24, 48 hours to reduce all of the irritated structures going to the site. You could think of that as inflammation or swelling. You're essentially vasoconstricting or slowing down how much blood flow is going to that area. But then when we use it chronically, when we're using it all the time, it's limiting blood flow to get to the tissue to actually heal it. So any kind of medicine can be too much. Or even exercise overdosing exercise can be too much, right? And can actually create harm. So, all of these topics that we're talking about is just be aware of how much is too much and how much is too little, and find that middle ground of what's really going to help you. Dosage really does matter with all of these things. So let's go into the interventional stuff, kind of that in between. Yeah. You've done the PT, you've done maybe chiro, you've done maybe acupuncture, massage. It's not making a difference. Maybe you got an injection. It's like, oh, that actually helped. Tell us about some of the other procedures that you've seen be helpful before we're launching to surgery here.
Oh,
I'm thinking ablations.
Yep,
I'm thinking
I was gonna
all these other types of interventional medicines.
Yeah, we have an entire specialty in medicine for this. That's physicians that train specifically to treat pain through procedures. So there's a whole host of options depending on what your ailment is or what your primary source of the pain is. And you can match that hopefully with a procedure that is likely to help. So our pain management colleagues traditionally start with steroids because it's a pretty straightforward process.
Minimally invasive.
Likely to help, yep. And then moving on from there, they have other options. A radiofrequency ablation, which is not medicine. That's using the needle to physically cauterize or burn the little sensory nerve fibers. And that can be done in a few different ways. It's pretty much just
blocking a signal, right?
Yep,
it's not fixing the problem. You're just kind of blocking the signal.
Turning off communication to that area, which is appropriate in some cases. There are specific nerve blocks. So if there's we can identify one specific nerve or area we think this is coming from. You can use the anesthetics or potentially steroids to block that specific nerve. And again, then you're using medicines and chemicals to do that. And then there's also things like electrical stimulation. So using electrical activity to actually kind of hijack or take over control of the nervous system to tell it to do or not do what we want it to do. So there's a few options in that world, and there's plenty more that maybe I'm not the expert to speak to, but there's a lot of options in that world to intervene.
I really hope that emphasizes that there are so many options, right? And a skilled professional can help guide you to the best option for your customized needs.
Yeah.
That is all of our role, whether you're being physical therapy, interventional medicine, primary care, even in your role being in neurosurgery. All of our job is to help know what's out there in these resources so we can funnel you to the right thing that's going to help you. Because your symptoms and what you're having is typically going to be a guide for us to know where to start.
Yeah.
And sometimes you're in the wrong office.
Mm-hmm.
And that's all of our jobs to determine you're actually in the wrong space right now.
Mm-hmm.
Let me get you to the right person, and they will help you from there.
Right.
I had one patient, we did a rounds on this about a year and a half ago, I think. 42-year-old female came into the clinic, her back after weightlifting, if you remember this story.
Mm-hmm.
And I was treating her for 4 or 5 visits, and I've treated a lot of really intense acute low back pain just
Mm-hmm.
right at, after they got injured, and it was a very, very normal case. Asked her all the red flag questions, which we'll talk about here in a minute. She was cleared with all the red flags. Just started treating her. She got a little better each session, but it did follow the pattern. Got to the 5th session, and she came, and her husband was by 2 arms walking her into the clinic. It took her about 20 minutes to get from her car to in the clinic bed. But I was like, something's not right. Tell me more. And she said, I was laughing with my friend last night, and
Mm-hmm.
just hysterically, we was having a good time. And now I'm like in so much pain I can't even control. So I sent her for an MRI literally right then, walked into the clinic an hour later. She was walking out from the MRI, and the radiologist called me and said that she's got around 18 pathological fractures all down her spine and has tumors that have invaded everything.
Mm-hmm.
And she said, what would you like me to do? She's going to her car right now, and 2 of them are unstable.
Mm-hmm.
So me in my young practice, I'm 4 years out of school. I call all my friends. I'm like, well, first of all, I just sent her to the emergency room.
Yeah.
Because there's those unstable fractures. But I also knew the emergency room probably wouldn't guide it to the right spot. So I started calling around all my friends and figured out, okay, these are the next steps. But long story short, she was not in the right office, obviously with her condition, and we expedite that to the next spot.
Yeah.
And your guys' team got involved, interventional medicine got involved, and there's a whole long story about that. Unfortunately, she ended up passing away. But sometimes they're in the wrong office, and we need to direct them to the right office.
Yeah.
So let's dive into those red flags and into actually this next part is like, when is surgery life-changing? You've seen so many of those cases where people had the right things. What are those things that you're looking for on clinical exam?
Yeah, in the spine, the two big conditions that would say are more urgent are, we call it cauda equina syndrome, so compression on the main spinal canal, the nerve roots in the low back, and then compression on the spinal cord, and we say that's myelopathy. So you're
really
at risk.
Listen to what he's talking about here. These are the two things they look for to expedite surgery.
Yep, these are the two that are actually urgent cases and actually quite rare. So cauda equina syndrome is what every practitioner in most every setting will learn in school, because that's the one that may show up in your office, and that's the one you don't want to miss. But that doesn't necessarily mean that's what's happening to everybody or all the time. So narrowing or pinching on the main central canal in your low back can cause the nerve roots to then start to dysfunction. It's not necessarily saying that, oh, my back hurts or my one leg is hurting or achy or numb. These are the nerve roots actually not functioning anymore. So the classic symptoms are numbness in the groin or perineum area, in the saddle area, the profound weakness. So we say foot drop, where it's not because it's painful, but your legs just don't function. You tell your foot to move and it does not move. And then incontinence, so losing your autonomics. Excuse me. So you're losing your autonomic function. That's your bowel and bladder control and the things that your body would just regulate on its own.
How does that actually look for a patient?
The incontinence is pretty noticeable. So it can either be significant urinary retention, meaning that you cannot go to the bathroom, nothing's coming out.
You try and it just doesn't go.
It's not working. Or people lose complete control of holding it in. And that's not like, oh, I just feel like I have to go all the time. This is, I went to the bathroom 5 minutes ago, and now I'm sitting down comfortably, and without any sense of urgency, I just notice I've wet myself, right? These are pretty significant noticeable features.
So what happens when someone comes into the clinic and has those symptoms? What do you do?
Yep. If that's the symptoms of the emergent condition, then we need to see it. So it's an emergent or urgent scan, an MRI scan. And again, you can't just treat symptoms. You can't just treat an MRI. They have to match. So if they have the symptoms, order the scan. We look at an MRI. And if the MRI confirms there's critical stenosis or pinching on the nerve roots, they match. And then that's an urgent surgery. You just need to get that addressed, because those don't always get better. Those
and how quickly do you get those cases into surgery?
Yeah, the true emergency, those symptoms, the research will suggest 48 hours. So if you can address it within 48 hours of symptom onset, you have a much higher success rate or
do you guys typically get them in within 48 hours for surgery?
Yeah, it would be through the emergency room.
Oh, okay.
Yeah, that's probably not one that we would be able to do much in the clinic other than just direct them where to go. But that's the true emergency.
So they go to the emergency room and then they expedite them to you guys to get into surgery.
It's typically the surgeon that's on call for that facility would be making those decisions.
I see. Okay. And then what's the difference between cauda equina syndrome and myelopathy?
Myelopathy, so in the low back, it's not your solid spinal cord. It's the loose nerve roots. So it's a little bit different. Up in your thoracic spine or in your neck is a solid spinal cord. So similar though, it's narrowing or compression in that main central canal, but now you've actually injured the spinal cord itself. And that shows up as really everything downstream. That information only goes one direction. So if you injure something in the neck, then you can lose function in both arms, both legs. So people feel the numbness and weird sensations equally in both sides, arms and legs.
And that is key. I really want to emphasize that it's on both sides.
Correct, yeah.
Right? Because typically when you have radicular pain or radiating pain, it's on one side. But if you're having it on both sides,
That's
it's a big
different. Yep, that's something different. Again, it's function more than anything. So you're losing strength, but not just strength, it's fine motor skills and dexterity. So people feel like they can't button shirts or have a hard time with dinner utensils. They're dropping things. You'll see someone hold a glass of water, but they have to support it underneath because they don't trust their grip strength to hold that glass of water anymore.
Doing it with both hands.
Yep, and then you can see people lose their stability and balance with their gait pattern. They're uneasy on their feet. And then again, kind of similar symptoms down the legs as well. Those would be the concerning signs that it's a spinal cord injury potentially.
So, yeah, all these are very, very emergent. Talk to us about the red flags, the additional red flags that you look for, questions you ask to determine if really surgery is, you need this.
Mechanism is helpful. Is this something that's just I've been this way for 5 years? Or is it I fell while I was body surfing and cranked my neck back and then I couldn't feel anything?
About a fracture, right? Something like that.
Yeah, so trauma. We just had one recently. That was the story of like body surfing and got scorpioned and then had this incident of I just lost everything in my arms for about 5 minutes.
Yeah.
Right. So a mechanism or a history of the injury is a helpful thing. And then really just diving into those symptoms. There's a few physical exam findings that we do to confirm that or kind of steer that. So the exam in the clinic that could kind of help you understand that a little bit better as well.
Yeah. What are 2 to 3 things that you hear a lot of that people just get freaked out and they think they need surgery, but it's really not emergent?
The acute onset. So somebody will say, it just hit me out of nowhere and I didn't do anything. And then they try and in their mind put the pieces together. Well, I was extra busy in the garden the other day, or I did just get home from a flight, or right. But either way, symptoms are quick onset.
So not too serious. Severe
pain. Because those are prevalent. You notice that right away and it's debilitating. So it does naturally would make you anxious. If you just woke up one day and you said, my leg is on fire and it hurts and I can barely get out of bed, that would make anybody anxious.
Yeah.
And it's a legitimate problem, but it's probably not into that emergent category.
Yeah. Any others? Any others that you hear on a regular basis or just kind of really stresses people out?
Or if it gets acutely worse. That's another one where they say, yes, I've had back pain. It kind of comes and goes. I've been dealing with it. I know I have a problem. But just this week, it is way worse. And they will really stress and say, there's got to be something else happening. And sometimes if we are appropriate and repeat an MRI. Is there something different? But oftentimes
it's something change.
Yeah, oftentimes it is the same thing. It just, and I don't know that I could perfectly explain why, but we can see acute exacerbations or things just get worse, even though the pathology or what's happening is not changing much.
Yeah. A lot of when we talk about back pain, as we kind of wrap up this podcast, we talk about how there's multifactorial or multiple factors coming into this. It's not just the stress that happened. It's not just the mechanism or the way that you bent over. Mm-hmm. What other factors do people need to consider when we're talking about low back pain?
Is it degenerative or is it acute injury related? Mm-hmm. Those are 2 things that put you in different categories. The acute injury related issues are likely to get better. Injuries get better. Yeah. Degeneration probably not going to get better, but can be managed. And then I think just knowing that overall there's a process in place to make sure you get to the right place at the right time. Not everybody's a surgical candidate. Not everybody's a candidate for conservative care. Yeah. But I think getting in with a trusted provider can help you differentiate where to get started.
Yeah. Talk to us just briefly about what psychologically happens that can relate to back pain. What about sleep? What about nutrition? What about stress and anxiety? Mm-hmm. Like, how do those factors play a role into low back pain?
Chronic pain is that's a whole different animal. It wears on people. And typically if you are in pain and you're not sleeping well, if you're sleep deprived as well, then everything in life is miserable. Yeah. So that really puts people in a bad place. And you have to take that with a grain of salt when you're treating people in the clinic, and just knowing this person's been in pain for a long time. They're likely not sleeping. They're all out of
Probably
their
out of work.
routines.
Yeah.
May not be going to work. Financial stresses. There's a lot that goes into that. So having some grace and some patience with people is definitely needed, and understood that somebody's coming to you. Get a sense of what that situation is. It's a burden,
Yeah.
and just trying your best to
A
navigate that
lot of
appropriately.
factors to consider, and I would say if you are a patient and you've been in this area, I love that you said have grace for yourself. A piece I'd add is have grace for your providers. There's a lot that they're filtering through. There's a lot of decisions that are being made. I like to believe that we're really good at our jobs, and we're really good at connecting with people. We're really good at deciphering what's important, what's not. But there is so much volume of information that we need to put through our heads. So be patient with us too. That's my main plea.
Yeah.
My last question for you as we wrap this up, what additional advice do you hope that everyone that is considering surgery or not with back pain would know?
I would say trust the process. I use the analogy for a few things, but one analogy I really like is everybody knows the iPhone. It's an amazing product. It is awesome. Apparently is everybody's favorite. I'm not an iPhone user, but right. So Apple has created this awesome product that is an iPhone. And if I want an iPhone, it would be silly for me to go to the Apple store and say, I'm only going to talk to Steve Jobs. I know he's not alive anymore, but I'm going to go into the Apple store. I only want Steve Jobs as the only one that can help me because he's the one who made the iPhone.
Mm-hmm.
And that's nonsense.
Yeah.
The people in their position that are at the front of the store are the tech support, are the sales team. They are the specialists at what they are doing, and they will get you the best answer. So trusting the process of see your primary care provider. They know what they're doing. They have your best interest in mind. Get to your physical therapist. They are also on your team, and they are expert in what they are doing. And if you trust the process, you will get to the point you need to be.
Yeah, and I want to emphasize this as well. You go to a neurosurgeon, you're most likely not going to see the neurosurgeon. Right?
Mm-hmm.
You're going to see their physician assistant. Why is that?
It's the whole process is the same. The reason they start at physical therapy, it's a triage system. So the surgeon is uniquely qualified to do surgery.
Yeah.
If he is in the operating room, we're using the surgeon to the highest level of their skill set and their ability to help the community. And I don't do surgery, but I can definitely help triage and get the workup done and establish a diagnosis and make sure to be an advocate is really how I see myself, an advocate for the patient to get to where they need to be in a timely manner and in the right way. And the surgeon needs to be doing surgery.
Yeah.
It's not that they don't care. It's not that they don't want to be in clinic. Dr. Edwards loves clinic.
Yeah.
His favorite day of the week is when he gets to come to clinic and see people and talk to people. But the way that we can really expedite and get the patient to the right place is to trust the system. And when Dr. Edwards is needed, or when our neurosurgeon is needed, they have their eyes on things. And this is the system that for us, this is the system that he's built and put in place, and it functions really well.
Yeah, and I've actually heard Dr. Edwards, I know you were sitting there as well when he said this, but he said, my PAs are better than me at doing their job.
Right, yeah.
You would rather see my PA at that level than me.
Yeah.
Like, trust me. They're just so dang good at their job
Yeah.
that I am not even needed. My job is to do the surgery and do the surgery exceptionally well. Their job is to be the best at their job.
Yeah.
So if you do go in and you don't see the surgeon, that is why.
Yeah.
Because they have trained these PAs, these physician assistants, to be better than they were at that position.
Mm-hmm.
And these PAs get so dang good at it, no one is better at triaging than these physician assistants. So trust the process. I love that, the way we ended that. So thank you for joining us on this podcast, Alex. Appreciate what you do for the community and the community that Summit Brain and Spine has developed. It's really made a meaningful difference in my life. Obviously, it's influenced me to start this podcast of the healthcare revolution. So thank you for what you've done.
Yeah, I appreciate it. No, I'm happy to be here. No one person is ever going to have all the answers, and no one person is able to treat and do everything. So it certainly takes a team. It takes an army to really care for the community.
Absolutely. Thank you.